This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you. Okay, this is going to be Chapter 12, Heat Emergencies. And key concepts upon completion of this chapter. You'll understand the spectrum of heat illnesses, the pathophysiology of heat illness, 2 types of heat exhaustion, 2 types of heat stroke, field treatment of heat stroke, and complications associated with heat stroke. So heat illness, it claims lives every year. Untreated, there's a very high mortality in this. Paramedics must understand how the body adjusts to high temperatures. The body can decompensate and to support the body in its endeavors. Chief concern, heat stress to the body, cumulative, and this means all of this together. So high temperatures, high humidity, and dehydration combined is what gives us a heat injury. Unabated heat stress, the spectrum of heat illnesses, heat exhaustion to deadly heat stroke is the range that we're looking at here. So heat exhaustion, we pretty much depleted our system. Heat stroke, we have no compensatory mechanisms left. So let's take a look at this here for a second. So the core temperature, let's start right here with the ambient temperature. So the ambient temperature, the temperature outside, communicates with the cutaneous receptors, and those would be the ones on the skin. And this is a setting point to your thermoregulation center. Now this right here it's like a thermostat that's located in our brain, and very simply it can adjust itself higher. Well, sweating occurs, which has a loss of water and salt, and then increased cutaneous blood flow so that we can cool ourselves better, heat exchange with the environment, and all of this adjusts the core temperature. Now, if we're heat production, this is the overall kind of diagram here. If we need heat production, let's say it's cold outside and our receptors say, hey, I'm chilly, and we increase heat, this also adjusts core temperature. So a lot of things going on, a lot of systems getting feedback off of just simply raising the temperature of your body. So a physiology review. Regulatory systems, they attempt to maintain the body at about 98.6. And they're challenged by the external environment depending on what the temperate condition is outside. Evaporation, heat loss, thermolysis. Sweat reaches to the surface of the skin and it evaporates in the atmosphere. It takes heat with it whenever it does this to give off heat, so to speak. Heat index, function of the ambient temperature and humidity, creates a perceived temperature. So whenever you're listening to the news, the actual temperature is this, and then this is what it's going to feel like, is always said whenever they're talking about how hot it is. And this depends on the amount of humidity that's in the air. Pathophysiology of hyperthermia interferes with cellular metabolism, specifically the sodium-potassium pump. Increased heat and subsequently, like whenever the increase in heat occurs, the cell shrinks, causing the cell to lose sodium and elevate the sodium levels in the blood. Sodium-dependent action potentials, and this would be how you generate energy, are affected, and the person loses strength, has diminished reflexes, and has an altered mentation overall. Heat illness, the body's ability to compensate is overtaken by stressors, and this could be external heat stressors, high temperature, high humidity, internal heat production, decreased capacity to get rid of the heat, essentially. Includes heat fatigue, heat exhaustion, heat cramps, and heat stroke. Now, the differences between them: heat fatigue, decline in coordination and difficulty with task performance. Heat exhaustion, generalized weakness, poor muscle coordination, and alterations in mental status. Heat cramps, muscle spasms due to the loss of water or sodium. Heat stroke, there's two different types whenever we talk about heat stroke. There's exertional and classic. Exertional heat stroke results from strenuous physical activity. So you're out there and you're throwing hay, essentially. Not replacing the water and the salt like you should, and it can cause heat stroke or core body temperature elevation to the point where you can no longer compensate for it. Non-exertional heat stroke, classic heat stroke, usually seen in elderly patients because of their medical condition, age, or their inability to compensate for the change in temperature or humidity. Symptom patterns of heat exhaustion, salt depletion versus water depletion. And this is just a brief overview. They can generally have both, but we're just looking at this here. Signs and symptoms. So in the acclimatized patient, are they salt depleted? No, because they're acclimatized. Water depleted? Yes, very easily they could be water depleted. If we see thirst, salt depleted? No. Water depletion? Yes. Nausea, salt depletion? Yes. And water depletion? Yes. This is kind of a progressive thing. So the more of these symptoms we see, the more dependent we have on both of them. And vomiting generally occurs in salt depletion, but not in water depletion. Special cases, malignant hyperthermia, and this is caused by our anesthetics, or more specifically, a depolarizing paralytic. Succinylcholine will cause this. Untreated malignant hyperthermia, this is a medical emergency. It has about a 70% mortality rate. Symptoms, muscle rigidity and spasm, and a marked increase in end-tidal CO2 production. Treatment begins with stopping the succinylcholine, introducing hyperventilation with the goal of returning the end-tidal to CO2 to normal, and then sometimes dantrolene is utilized as well as an antidote. Decreases overall core temperature. So, history, consideration. High-risk population, construction, agriculture, restaurant workers, etc. Heat stroke types, there's two different types, exertional and classic. Syncope, loss of consciousness and seizures. Medications for this, sympathomimetics we need to know about. Psychotropics can also precipitate you to heat stroke. Cardiovascular medications can increase the patient's risk for heat stroke. Diseases and conditions like hyperthyroidism or phenochromocystoma, which is a tumor on your adrenaline gland. Last oral intake, and we're more specifically asking about when's the last time you drank some water or had a hydration intake. And then symptom onset time. Classic heat stroke tends to take days to develop. So they've been working at this or fighting this for days. Heat stroke in the homeless. The poor and homeless lack access to things like water, shelter, and air conditioning sometimes. May limit their water intake. Lack of bathroom facilities leads to dehydration as well. At risk for heat stroke, environmental exposure, impaired mobility, use of alcohol, lack of sunblock. So all of those factors precipitate the possibility of them going into heat stroke. Acclimatization is what is required to get your body acclimated to the surrounding environment. On examination, patient with heat strokes presents with various stages, sudden onset of altered mental state, approximately 80% of the cases, combination of delirium and hallucination and confusion, even coma. Physical symptoms are hypothermia signs, and this is table 12.4 in your book. Early stage, they're confused, heart rate's elevated, respirations are elevated, blood pressure is normal, skin is diaphoretic, they're still trying to compensate and cool, pulse pressures are normal, JVD is marked, increased perfusion, EKG should be normal. At the late stages, altered their mental status, coma, heart rate's elevated, respirations decline because of the altered mentation, hypotension on the blood pressure, and hydrosis, as far as the skin, is dry, widening pulse pressures, JVD is absent, maybe even flat neck veins, and then an EKG, ST wave elevations. And this would be from low perfusion and too much work upon the cardiac muscle. Assessment. Etiologies for hyperthermia. the things that cause them: heat stroke, malignant hypothermia, endocrine disorders, things like hyperthyroidism, and then serotonin syndrome. Drug overdose is probably our easiest pathway there, but anybody that takes serotonin-based medications could possibly find themselves in this category. Careful history, provide true hyperthermia origins or figure out what got them there. Treatment: core temperature of 107.6 exceeds the maximum cells can endure. They start to die from protein denaturing. Start treatment as soon as possible. Delays associated, if you have a delay, it's associated with about an 80% mortality rate in this if you don't jump on this. Considerations: remove from the environment, disrobe as needed, and aggressive treatment of the airway, breathing, and circulation. As far as cooling, evaporative techniques: gently spray cool mist over the patient and allow them to evaporate. Strategic ice packing, ice water immersion, placing the body in very cold water. Ice gastric lavage or gavage, used in conjunction with evaporative cooling. And strategic ice pack placing. This is active cooling, like aggressive active cooling if we're doing cold water gastric lavages on them. Special case of exertional rhabdomyolysis. Rhabdomyolysis is pretty much a condition where the muscles break down, and this rhabdomyolysis results of vigorous exercise, injures the skeletal muscle. Exertional rhabdomyolysis, greater for novel overexertion, and the treatment on this is going to be intravenous fluids. The breakdown of the muscle tissue can actually impede or hamper kidney function. Evaluation: heat stroke patients, seizures, particularly devastating, tenfold increase in heat production whenever they go into a seizure, so we should really try to keep them out of it. Excessive sweating, increased sodium loss, hyponatremia, lack of sodium in the blood, caused by excessive loss of sodium, excessive water intake, and medications. Early signs are increased thirst, muscle cramps, lethargy, skeletal muscle spasms. Common symptoms of this are going to be mental status changes, emesis, and nausea. Disposition: heat stroke is a true medical emergency. Requires rapid transport. Closest facility capable of providing cooling. External cooling started in the field is most advantageous to the patient. Other treatments: cardiopulmonary bypass, ECMO or extracorporeal membrane oxygenation, and then hyperbaric oxygen. All of the below treatments there, especially the ECMO, pulls the blood out and allows it to cool a little bit in another device. Also would help with oxygenation. Very simply, the patient has multiple increased demands because of the increased heat production of the body. Conclusion: body's constantly changing with many different stressors. Compensatory mechanisms which are activated by stressors are short-acting and temporary. Combat the stressors until removed. Paramedics provide balance to resume normal metabolism in the case of heat stroke. References for this were taken from Professional Paramedic Volume 2, Trauma Care and EMS Operations, Delmar Learning. And if you have any questions concerning this chapter, feel free to give me a call. My name is Roy Smith, smithr@imsa.net, or 405-219-7613. Thank you.